Welcome to The Explainer. Today we're taking a deep, postgraduate clinical dive into an illness that's honestly just as devastating as it is profoundly misunderstood. We're talking about myalgic encephalomyelitis, which you probably know as chronic fatigue syndrome, or ME/CFS. For decades now, patients dealing with this invisible illness have faced so much stigma, widespread skepticism, and constant misdiagnosis. So today we are focusing strictly on the clinical reality. We're going to unpack the multi-system pathophysiology, the exact diagnostic criteria, and the rigorous management of a condition that drastically alters millions of lives.
Okay, let's dive into this by completely reframing our understanding right out of the gate. Look, we've all felt tired, right? We've all been completely exhausted after a brutally long week. But the fatigue we see in ME/CFS, it is absolutely not that. What if profound fatigue isn't just about being tired, but a complete cellular-level multi-system breakdown? The fatigue here is an incapacitating lack of energy that literally stops a patient from doing their usual, everyday pre-illness activities. Think of it like a permanently drained battery that simply refuses to hold a charge, no matter how much rest you give it.
And the stakes here are massive. $51 billion. That is the estimated annual economic cost in the United States alone. That includes direct medical costs and lost income due to ME/CFS. To put that into perspective, this isn't just some rare niche condition. It's a massive public health crisis with a staggering socioeconomic impact, and it's totally comparable in its functional impairment to things like multiple sclerosis or congestive heart failure.
But honestly, here is the most shocking clinical reality of the whole thing. Studies show that 80% or even more of the people who actually meet the clinical criteria for ME/CFS haven't been formally diagnosed by a healthcare provider. There's no way around it. That means millions of people are suffering in the dark, without any validation, without a management plan, and totally without support. Our goal today is to bring that clinical picture out into the light.
Here is our roadmap for today. 1. Definition and epidemiology. 2. The 2015 diagnostic criteria. 3. Multi-system pathophysiology. 4. Diagnostic workup. And 5. Symptom-focused management.
Section 1. Definition and epidemiology. So who exactly gets this? Well, population-based studies estimate that anywhere from 836,000 to 3.3 million Americans have ME/CFS. And there's a really stark female predominance here. It's about 3 to 4 times more common in women than in men. Now, while the highest peak hits right in that middle age bracket of 40 to 50 years old, it's absolutely crucial to remember the age range is super broad. It affects kids, teenagers, and people of all races, ethnicities, and socioeconomic backgrounds. It doesn't discriminate.
You've probably noticed we're using the composite name ME/CFS. The naming history is actually heavily debated. Myalgic encephalomyelitis, or ME, implies inflammation of the brain and spinal cord, which, to be fair, hasn't been definitively proven in every single case. On the flip side, chronic fatigue syndrome, or CFS, gets a lot of completely valid criticism because it trivializes a devastating disease. It kind of makes it sound like the everyday fatigue we all experience. So the composite ME/CFS was adopted to bridge that gap and acknowledge the biological severity of the illness.
Section 2. The 2015 diagnostic criteria.
Listen, if you take away only one single concept from this whole explainer, make it this one: post-exertional malaise, or PEM. It's the absolute hallmark of the disease. PEM is a severe relapse in symptoms triggered by physical, emotional, or even mental exertion that the person would have completely tolerated before getting sick. We're talking about a simple walk around the block, a stressful phone call, or just reading a heavy document triggering a crash that lasts for days or even weeks. It's a profoundly abnormal physiological response to exertion. Back in 2015, the Institute of Medicine set up a pretty straightforward diagnostic framework. It centers on a core triad of symptoms that have to be present for at least 6 months. That's profound limiting fatigue, post-exertional malaise, and unrefreshing sleep. But the triad alone isn't enough. It has to be accompanied by at least one of 2 secondary features: either cognitive impairment, which patients usually call brain fog, or orthostatic intolerance, meaning their symptoms get severely worse just by standing upright.
Section 3. Multi-system pathophysiology. Now, what's really interesting about this slide is the well-documented connection between ME/CFS and viral triggers. A whole bunch of different pathogens like Epstein-Barr virus, Q fever, Giardia, and SARS-CoV-2 can act as infectious triggers.
While most people bounce back from these acute illnesses, approximately 10% of infected individuals stay sick for over 6 months, developing a post-infectious fatiguing syndrome that basically mimics, or just outright becomes, ME/CFS. This exact overlap has finally brought some long overdue clinical awareness to the condition, mostly thanks to the spotlight on long COVID.
And this brilliantly illustrates what happens next. Once that viral trigger is pulled, a unifying multi-system breakdown happens. The illness is definitely not localized to just one organ. We're looking at major dysfunction across the central nervous system, abnormalities in the hypothalamic pituitary adrenal axis, and autonomic nervous system anomalies, which is what causes that severe orthostatic intolerance we talked about. We also see marked immune system alterations and deep metabolic dysregulation. It's basically a complex web of homeostatic systems that are all misfiring at once, heavily influenced by genetics, stress, and the environment.
Section 4. Diagnostic Workup.
So navigating this diagnostic maze requires a really meticulous clinical evaluation. Step 1 is a super deep dive into the clinical history. Step 2 often involves a stand test to check for postural orthostatic tachycardia syndrome, right alongside a mental health screen. Step 3, that's your standard laboratory panels, checking blood counts, thyroid, iron, celiac screens, and inflammatory markers. But wait, here's the catch. In ME/CFS, these routine labs almost always come back perfectly normal. Why? Because standard labs just don't measure cellular energy deficits or subtle autonomic failures. So step 4 is recognizing that these tests are actually primarily used to exclude other fatiguing mimics. ME/CFS is diagnosed by the specific clinical symptom profile, not by a single magic blood test.
Section 5. Symptom Focus Management. Since there are no approved cure-all drugs right now, the crucial point in management is understanding and breaking this specific cycle: push and crash. Patients desperately want their lives back, so naturally they push themselves on the few good days they actually have. But because of that post-exertional malaise we discussed, this overexertion leads directly to a devastating crash. And that crash completely negates any functional gains they thought they were making. Educating patients to avoid this trap is absolute step 1.
The main actionable approach to breaking that cycle is called pacing. It's meticulous activity management to limit PEM and maintain a tolerable baseline without letting the body decondition. We also rely heavily on non-pharmacological strategies for sleep and pain. Now, when medications are used for things like sleep disturbances or orthostatic intolerance, doctors have to exercise extreme caution. ME/CFS patients are remarkably sensitive to medications. The golden rule clinically is to start at much lower doses than usual and increase incredibly slowly. Oh, and strictly avoid narcotics.
We've covered a lot today. The staggering epidemiology, the hallmark of post-exertional malaise, the total multi-system collapse, and the absolute necessity of pacing. So I want to leave you with this final thought. Now that you understand the reality of ME/CFS, how will you view chronic invisible illnesses going forward? Just because a disease doesn't flag a standard routine lab test doesn't mean the biological reality isn't happening right in front of you. It means we have to look closer, truly listen to the patient, and trust the clinical criteria. Thank you so much for joining me on The Explainer. Keep questioning, keep learning, and I'll see you next time.